school when it comes to racism, both interpersonal and structural, as it relates to residency, faculty experiences, and ultimately what I think we're all here for, which is patient care and improving outcomes, and ultimately also addressing racial health disparities. So I'm going to start by telling you all a story, which contributed to me getting interested in this. So, in my third year of medical school, the first time I had a Black male resident was three quarters of the way through. I was on my psychiatry rotation, and for the first time ever, I actually felt like, prior to then, I had residents invested in me, but no one was ever so invested in my learning and like attentive to my interactions with patients. And we had many interactions specifically with young Black men who suffered of schizophrenia, bipolar disorder. And ultimately, he wrote what I thought was the most thoughtful evaluation I had ever gotten from a resident before. And some of the things that he highlighted were like, I have the making of an excellent clinician, great professionalism, special gift with connecting with patients, the things that ultimately I think you would probably want in a future physician. And although this is not the first time that I had gotten this kind of feedback, and even on this rotation, I did get this kind of feedback. But it felt special because I'd never gotten feedback at all, period, from a Black male resident. The attending on this rotation was white. And when he turned his evaluations in, it was empty. Now, usually when people submit if someone doesn't plan on evaluating a student, they just don't fill it out. They forget for a million reasons, but this one attending did fill my evaluation out, wrote where he observed me and what I had done during the rotation, but had nothing, absolutely nothing to say in the narrative portion of the evaluation that would ultimately belong on my transcript. He did have some formative feedback for me, and the formative section of our evaluations here at Yale are more so, sort of like where you would give someone feedback and advice for the future. And so in this case, sometimes people will also use that to complain about a student or to criticize whatever a student did. So in this attending thing was that I struggle with presenting the psychiatric exam, which I did. There are lots of idiosyncrasies about presenting psych patients that to me made no sense, especially having been on all the other rotations prior to then. Nonetheless, after that, I emailed my clerkship director and asked, hey, I noticed the attending for this specific block of the rotation had nothing to say about my performance that would ultimately go into my transcript, but the resident had a lot to say, which I thought was positive. Can you make sure that gets included in my evaluation? The clerkship director's answer was, sorry, we only want evaluations from the attendings, and it's too late anyways, it's school policy. But it doesn't matter because you did so well on psychiatry. We're really impressed. And it's true. I crushed, probably was my best performance of third year. If I wanted to be a psychiatrist, I think I'd be a great psychiatrist. But what if I were in a situation where I actually wanted to do psychiatry and also had been like a borderline student throughout the rotation? I would have missed out on this opportunity of a great evaluation from a resident who was invested in me, which was discounted, whereas the one white male attending had nothing to say about my performance. And I'm saying this because in medical education and in medicine in general, we sort of adopt rules, right, that are passed down to us from before we even get to where we are, and we sort of just follow them. You have all these kind of like idiosyncratic policies that sometimes make no sense and are tied to perhaps like things that we value. And if you think about the hierarchy in medical education, more often than not, like for me, I'm way more likely to have a Black resident than I am to have a Black attending. In fact, I've never had a Black attending who could actually like fill out an evaluation for me. One time I worked with a Black attending, it was a C-section at 3:00 in the morning. Another time my sister team's attending was covering for my actual attending. So if you think about it, and in contrast, I've had 4 Black residents. So knowing what we know about racism, bias, and whatnot, I am way less likely to get this kind of evaluation from an attending than I would from a resident. But I found myself in a structure where the attending's evaluation mattered more. Not, it's not the fault of the clerkship director, just kind of the way the dominoes fall when, when we would think about the structure of medical education. So given that, so here are my objectives today. First, the agenda. So I'm going to share the learning objectives. Why do I think this matters, and why should everyone care? I do want to define some specific terms. I'm going to review the evidence that covers disparities in educational outcomes and experiences across the span of medical school. Sort of share some supporting mechanisms that explain these disparities and both micro level and macro level implication. Micro, I mean at the person level, and macro, societal level. So first learning objective is for everyone to become acquainted with the theory of racialized organization. This was a paper that came out in the sociology literature written by Victor Ray. He's at University of Iowa. And then to apply this theory to each one's analysis of medical education or other structures that you might be involved with. And to understand the implications of racialization of medical education for workforce diversity efforts, as well as racial health disparities. So why do I think this matters? First, this is a case or an argument that doesn't get made nearly as often as the other ones that I've heard, but I think when we think about a career in medicine in this country, especially for people who come from less privileged backgrounds, it's a path to financial stability in ways that many other careers aren't. And if you've looked around in the hospital where you work, most Black people who work in healthcare are low wage employees, right? And as you go up that sort of hierarchy, it gets less and less Black. So I think being able to go to medical school, finish your medical education, become a physician or a consultant or whatever it is that one wants to do, it is a path to financial stability. So it's a matter of fairness, and that everyone sort of gets the opportunity, if desired, right, to complete a medical education. The other piece of this is a kind of utilitarian argument that gets made way more often, is that you have diverse work teams. That would be a benefit to addressing healthcare disparities. Diverse teams tend to be more creative, they're better at solving problems, they're more innovative. And it's actually been shown, not just diverse teams, but people who are in the minority in their fields tend to be more creative. So that this is a study that came out just earlier this year. And this is, they looked at both racial and gender minority. And so, for instance, non-whites in sociology had PhD dissertations that were significantly more creative than their white counterparts, right? And you see the same thing with women. And if you flip that script, men in nutrition, this isn't shown on this particular slide, but like men in nutrition end up producing work that is considered to be or judged as more creative and impactful. So there is something about being a minority in the field that changes, or that gives you a special outlook, and that contributes to creativity. Now, for me, you look at the demographics. So Black people have been 13% of the US population for years now. We make 5% of all US physicians, and even smaller in academia is 3.6% of physicians in academia are Black. Over the past, 30 years, it's been a steady decrease of representation of Black physicians, specifically in clinical specialties in academia. I was born in '93, by the way, so to put that in perspective. And this is across all ranks, right? Except OBGYN, where there's been an increase in the representation of Black women, but still a decrease in representation of Black men. And that might be more so a general function of the fact that there's been like a male exodus out of OBGYN. And OB is the most racially diverse specialty, both at the residency and attending physician level. There's been this continued underrepresentation of Black students in medical school. And if you look at the trends, so 1996, that's when my younger brother was born, 24 years ago. Since 96, and the most recently available data that I was able to pull stops in 2015, but there's basically been nearly the same number of Black students that get into medical school, right? Somewhere around 1,200 students, regardless of the number of applicants. And in fact, between 2002 and 2015, the odds of getting into medical school has only gone down for Black applicants. And of course, I'm not adjusting for whatever other factors that contribute to that, but it's like we reached a ceiling at some point and things haven't really been moving. And I mean, for me, it's not super surprising, but it is a reason to care about this issue. So next, I want to talk about this framework, right? The theory of racialized organizations. And so part of why I think it's useful is because typically we think of organizations as just bureaucracies that are race neutral. It's just random rules, and it's more so perhaps the people within the organizations that that maybe make the rules one way or another. And the other piece of this is a lot of times when we analyze organizations in conversations, we don't tend to think about the history of these organizations. And when you do, you realize, these organizations were founded on many different axes of oppression, right? So for instance, I'll pick a random example. Harvard Law School was being scrutinized a few years ago because all of the money that was used to found Harvard Law School was from slavery, from Antigua and Barbuda. So thinking about what this means, typically a racialized organization would be an organization where basically certain racial groups have diminished agency. And when you think about agency, it's sort of this ability to stick up for yourself, stand up for yourself. But sociologists specifically think of it as a matter of time and power. And so who has time to do what? And if you think, for instance, being poor in this country is so much about managing your time, right? You got to stand in line for food stamps. If you don't show up on time to a certain office, the door gets shut on you, and then if you don't show up on time to pick up your kids, they call CPS on you. Like, managing time is so key when you think about agency. And so within organizations, so I'm going to think about medical schools and safe faculty, right? You'll hear that oftentimes your minority faculty will say a lot of their time gets eaten up because they are being sort of like conscripted in doing work that they were never hired for in the first place, which is basically, for a lot of them, diversity work. And some people do enjoy doing that work anyways, and it becomes part of their actual job. But for the most part, minority tax eats up a lot of people's time, and at the student level too, in a way that then our time for what would be like agentic endeavors is significantly reduced. There is a legitimate unequal distribution of resources in racialized organizations, right? There has been study after study. This also applied to gendered organizations, and of course, gender and race are intertwined. There are racial disparities in earnings. You name the field, you'll find it. The third thing is whiteness is a credential in racialized organizations, and we notice in so many different ways, right? Where if you've been on a search committee before, the concept of fit comes up a lot, or even if you've evaluated people for a residency, right? Fit, like, oh, how's this person going to fit here? And oftentimes that is code for, whiteness, proximity to whiteness, ability to perform whiteness. And that's why affirmative action, for instance, right? Schools or institutions that take that seriously do so on the basis of considering that truly being white is a credential, as much as people may not realize it. And so trying to sort of like offset that nature is part of organizations realizing that. And then the fourth tenet is decoupling of formal rules from organizational practices, which is often racialized. So for instance, you have organizations that are committed to diversity and inclusion, but yet somehow, there would even be an office for diversity and inclusion, and again, yet somehow what happens in real life is there is no progress, right? There's just sort of like disconnect between what the formal rules are and what the actual organizational practices are, right? The AAMC and their commitment to diversity and inclusion and addressing health disparities and whatnot. And yet literally every year it's 1,200 medical students that get admitted and there's no movement, right? This is the fourth tenet of what is considered a racialized organization. All right, I'm going to move on from here. So think about key definitions. So culture. Um, so cultural anthropologists define culture as a system of inherited, I mean, there are many definitions, but this is one that I really like. A system of inherited conceptions expressed in symbolic forms by means of which people communicate, perpetuate, and develop their knowledge about and attitudes towards life. So culture is so key because as I mentioned earlier, it can be random. You know, we inherit things that shape our perception and we just kind of keep going. Um, uh, and if we don't ever challenge it, things don't change, even though we might express commitment towards change. And then I do want to talk about stereotype threat, just defining it ahead. So this is something that occurs in an environment when a negative stereotype about a specific individual's group status becomes salient, which triggers a physiological response. And it can include anxiety, negative cognitions and emotions, physiological arousal, and even reduction in performance, expectations, efforts, self-control, and whatnot. And the last point I want to make is about intersectionality. I didn't write this here, but basically race, class, gender, nationality, sexual orientation, these are all inextricably linked sort of layers of identity. And I think oftentimes when we think about intersectionality, what people think is that the sort of more layers of identity that make you different from a white man, the worse off you are. But I want us to think about them as rather either not having like additive effect on your experience, but rather being like effect modifiers or mediators of an experience. So for instance, you think about punishment of children in schools, right? Black boys and Black girls get punished in schools for similar reasons, but in different ways, right? This has been studied. So I just wanted to, put that into context with what I'm going to discuss next. And the other thing I'm going to say is all of this stuff is performative, like because they are ultimately social constructs, right? You can sort of like try to perform your way out of the other, your interlocutor's perception of like what your race and your gender are. But of course, it has its limitation. And this was a yearbook photo from a high school graduate who said anything is possible when you sound Caucasian on the phone. And Black people in the audience, you probably know about putting your white voice when you call customer service. This is like a thing. That's what I mean when I say these social constructs are performative to an extent. So I want to talk about my defining pillars of the medical school experience, and none of this is going to be foreign to you all probably. So first, school structure. So I think about the culture generally, and then defined culture earlier. The pre-clerkship years, which I think of as a relationship building phase. We spend a lot of time in the classroom, spend a lot of time in small groups, and it is really an opportunity to build relationships with our classmates, colleagues, people who are going to be ultimately, right, like potentially the leaders or in the trenches with us like 10, 20, 30 years down the line. And then the clerkships year, the sort of like professionalization phase, right? It's very much an apprenticeship. You tend to be mostly on your own with a team of people who already know what they're doing. And, a lot of what goes on in the clerkship is just observing what people are doing and performing accordingly. And then the other thing I want to think of is career advancement opportunities and mentorship. And lastly, the residency application process. So first, let's think about school culture. There's not a lot of research done on this, and this is actually an area that should be investigated further. But in my experience, a lot of things that the medical school sponsors, and it's, again, when culture neutral, random, or supposedly neutral and random, can be really cost prohibitive, right? The camping trips, the skiing trips, the galas, and we don't necessarily all come from similar backgrounds when it comes to like having pocket money, and activities tend to be centered around what is considered sort of dominant white culture. And for minority students like myself, there's usually sort of a pressure to be a cultural ambassador because we are underrepresented, but also kind of a pressure to assimilate because we want to make friends and we want to network with the people that we're here in school with. And oftentimes, students will report that there's a colorblind approach to student support. Frequently, there is a tense racial climate. I can tell you from my own experience. It also happens in the classroom, which is what I'm going to talk about next. So in the pre-clerkship phase, lots of studies have been done on this. People report frequent microaggressions, but also a lack of understanding from peers, administration, and faculty. And what do I mean by lack of understanding here? So anytime you are a minority in a group, there is often a need to also have like a in-group, almost kind of like a protective space. And students do report that their white friends or non-minority friends would, how am I gonna say, non-minority friends would question their need for wanting to be in a group, like being part of SNMA or going to the SNMA conference, which again speaks to sort of lack of racial awareness of most people in medical school. And social isolation is a huge issue. I have personally dealt with it. And there's actually data on this. So Rachel Harderman, she's an epidemiologist at the University of Minnesota. Her PhD dissertation was on the experience of minority medical students at this intersection of race, class, and gender. And she finds, for instance, that especially Black male medical students express having lower social support systems and coping mechanisms. And it makes sense. Like in my class here, we're 16 Black people, there are 5 Black men and 11 Black girls. If you walk into the auditorium, usually the girls are like, they all sit together. And that's not really a thing among us guys. And part of it has a lot to do with gender expression, masculinity, because even among all the students in the cohort that Dr. Hardeman studied, in general, women had better coping mechanisms and support systems than men. There's this concept of the conscripted curriculum where as pre-clerkship medical students, oftentimes we will be literally conscripted into serving as educators for our classmates. I remember at the end of an ophthalmology lecture one day, I walked up to the lecturer and I said, hey, I noticed you sort of made a conflation between race and biology in ways that I don't think you have evidence. I mean, that's not how I said it, but that's how I felt. I don't think there's evidence around this. And she said, you make a great point. That's why we need more Black ophthalmologists. Why don't you teach us how to do this, right? There's this thing about faculty often asking minority students to be the teachers when it comes to matters related to health equity, which one devalues the fact that, this is a well-studied area that often, there are professionals at these different medical schools who do this work, but it also puts us in a teacher position where we're no longer learning and we're supposed to be learning and add to the minority tax. I mean, I can't tell you the number of times I've thought, oh my God, I'm doing too much for this place. What is happening to my own education? When I was studying for step 1, I started regretting everything that I did because I said, well, if I failed this, it would have all been, what would have been the point? I ended up doing fine, but I really, really, as I was struggling throughout my studying period, really regretted everything I did for this school. And interestingly, on the flip side, we experience this kind of like experience of our contributions being devalued around nearly everything else. So I personally don't feel like my opinion is valued on things that actually I do hold an expertise on in ways that I didn't always when it comes to racial health disparities. I mean, I eventually got to study this nearly by, because I had to, but that's not what my expertise was in. And even in small groups, people will tell you in their workshops where sometimes maybe, and this is something that also happens to women, right? When you say something, the professor doesn't listen, and a man says it next, and the professor, oh, good job, right? This women call it heap eating, and you can imagine that is taxing, and ultimately people, report basically divesting from the general discourse. So then you get to the clerkships, right? Okay, this is supposed to be the fun part of med school, or at least more fun, where you get to sort of eventually put to practice what you've been learning for the last 18 to 24 months. But actually, what a lot of students report is feeling excluded from the learning environment and also the social aspects of the workplace, which ultimately contributes to isolation. So, and this happens in different ways, right? I remember being on a rotation where actually I was really interested in what was going on. I was like, oh, I think I want to do this for a living. And you usually feel it way more often when you're on a rotation with another student who is not of the same minority group, right? So you start witnessing this sort of like preferential treatment. I would talk to my classmate who would tell me, sometimes like if you're in a rotation with someone who's white, they have this sort of like instant connection with the resident or even the attending. Sometimes, at the switch from one rotation from to another, in case you're not going to be with another student, we give each other sign out, right? Oh, this attending, he'll ask you a ton of questions. Oh, this attending, he'll let you do a lot in the OR. And then you get to that rotation, and to your surprise, the attending won't speak to you in the OR. They might actually ask you a ton more questions instead, like the attendings that are not known for asking questions. And so all of this activates stereotype threat, like I mentioned earlier. And so this is a recent study, just came out like last week out of UCSF. Justin Bullock is a second-year internal medicine resident. The study showed stereotype threat is experienced by 82% of Black students compared to 4% of white students. The second highest number of students who experienced stereotype threat in the study were Asian students. And I've been in focus groups for studies on this matter where, fellow classmates who are of Asian descent express, feeling cheated out of opportunity. And obviously, Asian Americans are overrepresented in medicine, but there's this element of being underrepresented in leadership positions, which potentially, can plays to this general experience that people report. You look at grade distribution, right? On average, across clerkships, Black students tend to have the lowest grades. Even, you adjust for whatever you want. So the Boat Wright study on Alpha Omega Alpha, which I'll talk about next, they looked at applicants that turned in residency applications to Yale. Obviously, a little different sample from the national average, but on average, all the Black students in this sample had lower grades than the white students, even, and it's not the only study that looks at this. But interestingly, if you look at studies that, qualitative work looking at students' perception when it comes to grading, students will report first, they don't really trust the quality of their evaluations. There's this kind of like high variability in grading quality, and there is an idiosyncratic focus on performance over improvement. Again, culture, right? This is random. Why is it that the person who shows up on day one knowing everything, that's what we value more than, say, the person who shows up on day one knowing 50% and finishes a rotation having improved by so much. And not listed here, but there is an element of, who is an insider. There are students whose parents are physicians. There are students who older siblings are physicians. I have a friend, both his older brothers are physicians, both his parents are physicians. One of them wrote the immunology book that we read, and love him dearly, but that's the experience that some people have that many of us do not have, especially if we're minority, low income, and whatnot. And you look at the language that is used in evaluations, right? Notwithstanding grading. This is also a study done by Yale faculty, including Darwin, who I mentioned earlier. And so, for instance, white students are way more likely to be described using standout words like excellent, whereas Black students are more likely to be described using sort of rhinestone habits like, oh, persistent, competent. Honestly, when I read that in my evaluation, I'm like, are you serious? It can be a little, almost like a backhand compliment, like, oh, he's fine, right? Whereas like, and again, this is adjusting for everything else that you can sort of like quantify. And of course, not surprisingly so, terms that are related to compassion, like, oh, caring, are more likely to be used to describe female students. And so you think about the ways in which grading disparities occur. There's so many different factors here, right? There are the student factors, right? We obviously have variable performance. Students experience microaggressions, which again, triggers stereotype threat. And if you're a minority student, you really do have lower social capital. And then there are the sort of like faculty present or evaluator factors in general, right? Some people who are quote unquote colorblind, faculty who mistreat students, faculty who are burnt out and don't fill out evaluations, and just variable teaching. There is a study that just came out the other day that showed that the amount of time a student spends with the person who evaluates them is a lead contributor to the quality of the grade that they're going to get. And then there's school policies, right? So in some schools, you know, shelf exams are a thing. We don't have shelf exams at Yale. We have our own internal exams that are formative, and I find them to be more useful than shelves that just give you a grade. But they don't count towards our final grade for the clerkship. But in a lot of schools, it's, you know, students would say, you know, my evaluations are stellar, I performed great, everyone left me fantastic feedback, but I didn't do well on the shelf. And so that's why I didn't get honors. Again, there's this sort of like idiosyncratic focus on numbers, right, as opposed to other things. And also, what do the appeal rules look like? So I appealed that, you know, if it wasn't a real appeal, I just asked, hey, can you include the residence evaluation? I was like, oh, sorry, it's been 60 days, we can't add it, it's the school's rules. I mean, those are the rules, but we probably should think about how do the rules actually end up affecting, you know, the disparities that we are observing in student grading. Then what is a learning environment, right? The type of patients. Students face microaggressions from patients. Variability in sites. So lots of medical schools have both like the sort of like big fancy hospital, and so I use NYU as a good example because it's COVID. You know, there's Bellevue and then there's Tisch next door. The experience is different when you work at Tisch versus at Bellevue, just because of resources that are available. And so, you know, if you can't adapt to that difference, then perhaps that might affect your performance. And then there's this concept of obviously rapidly changing teams. This is an emergency department grand round, so y'all know about this, right? You show up on shift one day, you're working with attending X. On the clerkships, it happens even on internal medicine. The thing that was the most frustrating to me my first month, I just couldn't adjust week by week. I had a new attending every week, and it took me till like Thursday by the time I figured out what works with this attending and what doesn't. And you can imagine, right, with all the other factors that I just described, that makes it really difficult to be able to perform in the way that people expect you to. So then let's think about career advancing opportunities. So AOA, everyone knows it. It's the, forgive me, it's the Honor Society in medical school, right? So Darwin Boatwright, again, led the study at Yale that showed, you know, among this pool of applicants out of here who you know, applied to Yale programs, Black applicants were six times less likely to be inducted in AOA, notwithstanding what their step one scores were, what their clerkship grades were, like all of those things. Asian students in this cohort were 2 times less likely to be inducted in AOA. There's a similar study that was done out of UCSF, more so internally, so where in 1 year they noticed that URM students were 4 times less likely, not one, like several years in a row, 4 times less likely to be inducted in AOA. And then when they shifted to doing a more like holistic review, that reduced that disparity by 50%. And I think something about the AOA study struck me, right? It's not simply URM students, it's Black students and Asian students. And to me, what does that tell me? It's a lot about what are stereotypes that people, you know, ascribe onto others. Who is less likely to look white? And how do those stereotypes get wielded against people when they're coming up for, you know, certain kinds of promotion where perhaps subjective judgment can influence decision making, and also how much are you able to perform your way out of how you look, right? Again, that's what I mean by who's less likely to look white. And I think it's the study's unique point is that the people most affected here are Black and Asian, not you know, not simply URM, but you know, something that I think is worth highlighting. And then the next thing about career advancement opportunities is research and mentorship, right? So we've already talked about the fact that there's just generally low faculty diversity. People report that generally as Black students, like faculty don't show nearly as much interest in them, and so end up having fewer opportunities. I have a friend who told me, you know, at the end of her clerkship year, she didn't feel like she had a single clinical mentor. And a lot of us end up finding research mentors from clinical experiences. Now, I'm going to talk about the thesis award. This is specific to Yale. So a lot of schools have AOA. We don't have AOA here, but we do have a requirement to produce a research thesis by the time we graduate. I think Yale and Northwestern are the two medical schools that require a literal thesis. Other schools may require a capstone project. And so in the study that was done here, although the study's focuses on gender disparities, I think what was the starkest for me was that URM, so Black, Native, and Hispanic students, were one, these, half as likely, or least likely to be nominated for honors, then after being nominated, half as likely to get honors. And only the odds for getting highest honors, which is like the pinnacle of how good your thesis is, 0.2. It's abysmal, it's pathetic. And one of the lead contributors to having to having all of these accolades is having an effective mentor. And again, I just talked about how effective, access to mentorship really shapes what your experience ends up being. Okay, I'm gonna shift to talking about residency next. So you apply to residency, things that matter a lot, right? Your MSP letter, your letters of recommendation, and your chair's letter, all of which are susceptible to bias for all the aforementioned reasons. Now, before we even get to the application, URM students have about 2 times the rate of attrition compared to non-URM students. And I'm sorry I didn't define this earlier. URM stands for underrepresented in medicine. So as defined by the AAMC, Black, Native, Hispanic, and more recently, Southeast Asian students. And then when you look at match rates, so for Black and Native students have the lowest odds of starting residency the same year as their white peers, right? But eventually, when you look at like 6 years after when they started medical school, it eventually evens out. But look at how abysmal these rates are, right? So the unadjusted odds, 0.37 for both groups, and 0.6 or 0.63, right? That is pathetic. All right. So then when we look at how residency applications are reviewed, right, there is generally this sort of like McNamara fallacy that is embraced. McNamara was the US Secretary of Defense during the Vietnam War, really focused on numbers. And, I mean, there's this sort of like emphasis on scores and on cutoffs and accolades like AOA. And ultimately you end up basically, sorting out, your students who are underprivileged, which by the way, I haven't mentioned this yet, right? But Black, Hispanic, and Native students on average have lower step 1 performance compared to their white and Asian counterparts. Then there's this sort of questionable value of high score cutoffs anyways, right? So the average step 1 score for a dermatology applicant is like 240. A lot of people will tell you, if you don't have a 240 and you're applying into derm, maybe consider doing something else. But does a 240 actually predict, right, how good a dermatologist you're going to be? I bet you it's not the case, right? There's a study that has shown that there's a certain score. This was specific to pediatrics, but like a 220 on step 1 was enough to predict that someone had like 97% chance to pass their pediatrics board. So why does it matter that someone has a 270 if ultimately what you want is someone who's going to pass their boards? Then there's this really high cost to applications. We'll talk about this more, but one, Black students in med school have lower income, and we're, again, more likely to have done not nearly as well as our counterparts on like the board exam. We have worse grades. Like all of the things that are supposed to make your application stand out for residency we're worse off. And so then you end up having to apply to more programs just to increase your chances, right? But unfortunately, there is this element of opportunity hoarding that happens among the students who are competitive. So for instance, 12% of internal medicine applicants hold over 50% of interviews. So then what's left for everyone else? Let's see. So then I want to talk about orthopedic surgery, right? Ortho is like one of the very most competitive specialties out there. So a study was done that showed not surprisingly so, like across the board, white and Asian ortho applicants have the highest step one scores and step two scores and the most likely to be in AOA. Hispanic students have the highest number of publications, and Black students have the highest number of volunteering experiences. And part of the conclusion from this study was that, you know, depending on what you choose to value as a program, honestly, students from all these backgrounds are sort of equally ready and competitive. But again, if you have a focus on numbers like step one, step two, or even publications, then your pool of applicants or your pool of eligible ranked, you know, applicants is going to look different. So it's worth reconsidering, you know, this again, the McNamara fallacy that focuses on numbers alone. You know, if a program director tomorrow decides, I want orthopedic surgeons who are focused on service, you probably will see a shift in what their ranks look like. Now look at this. I mean, in 2014, only 30% of Black orthopedic surgery applicants matched compared to 70% of white orthopedic surgery applicants. Now, I sure hope that they double applied into, you know, I don't know, ortho and general surgery and ended up matching somewhere. But I mean, this is really alarming, right? Especially knowing that, again, just the step one score itself and step two, like these things don't necessarily predict beyond a certain cutoff, like how good a doctor someone's going to be. Anyway, so I'm going to shift to, you know, explaining all of this. So whose medical schools are these? And by this, I mean, I'm not talking about the HBCUs. I went to Howard for undergrad. But you know, non-HBCUs. So, you know, way back when med school was only white, well, some medical school were like, you know, for white men and other medical schools were for white women. The role of Black men in med school back then was to be like the handler of the cadavers for medical students to learn anatomy from, right? Like medical schools, as I mentioned, like the historical funding of organizations is foundational to how we think about them as racialized organizations. Now, fast forward like 1910, right? We've all heard about the Flexner Report, which really changed how medical education takes place, right? Well, one of the things about the Flexner Report is it, not by itself, led to the closure of 13 medical schools at HBCU. So now, which left us with Meharry and Howard, and later on, there, you know, Morehouse School of Medicine was created like in the 1970s, but technically, so not technically an HBCU, but affiliated with Morehouse College. And it isn't the report itself that did this, right? The American Medical Education in the Medical Association embraced the recommendations of the Flexner Report, which then led to, you know, the domino falling of the, so, and this is a reminder, the AMA didn't let Black people in, you know, into, or Black physicians into their ranks at the time. Now, one of the striking things about the Flexner reports was that one of the suggestions was that Black people's medical education should focus on hygiene rather than surgery, and that they would serve as sanitarians to protect whites from common diseases like tuberculosis, right? So the general sort of like concept behind, or part of it behind the Flexner report was sort of like a relegation of Black medical students and future physicians to like a backseat that was mostly meant to just protect white people at the time from tuberculosis, which was ravaging through the Black community. And remember this hygiene rather than surgery, because it will come up again. So I want to think about socioeconomic differences next by race. So greater than 50% of medical students come from the top quintile of US household income. I think this is worth thinking about. Now, 31% of Black students compared to 8.8% of white students come from households that earn less than $50,000 a year. Now, 52%, so most white students in medical school, compared to only a quarter of Black students in medical school, come from households that earn over $150,000 a year. And this is just, you know, earnings, not thinking about wealth, because a lot of like, you know, high earning Black families will then have like siblings and cousins and nephews who are not earning nearly as much. And that sort of social network means that even if you're a high earning Black family, a lot of you just have a different set of responsibility, because again, in a lot of Black families, not everyone ends up being nearly as successful compared to what you see in other racial groups. Now, if you think about pre-medical school debt, so 62% of Black students start medical school with debt, and they're actually sorted in the buckets with the highest amount of debt, right? Whereas only 36% of white students start medical school with debt. Black students have a greater odds of contributing financially to family. I have several friends who use their loan money that is really, allocated and calculated for one person to live off of, right, to contribute to financial support of their families. Some people even take extra loans for that. And so if you think about performance in medical school, finances really drive many aspects of this, right? So who gets to buy the question bank that are going to be useful on the first day of med school and buy it for 4 years or 3 years or however long it's going to be when they have to take step 1 or step 2, versus who gets to buy the question bank for 60 days just for what's a dedicated study period. Who gets to take, 6 NBME practices. I mean, every single one of these NBMEs that you use to practice before a test is $60, right? Like, money really drives a lot of aspects of performance, and we don't really think about that nearly as much. And just going to make a plug for this book, The Privileged Poor, Anthony Abraham Jack. This is though specific to undergraduate students at elite colleges, but I think it's very applicable to people in medical school, because obviously this is kind of an elite profession. Yeah. All right. So then I want to talk about capital, right? Different forms of capital. Cultural capital is sort of like what you know. Do you know how to ski? Do you play tennis? I don't know. Do you know your different wines? Do you know your reds? Your different reds. Social capital is who you know. For instance, like I may have mentioned this earlier already, 20% of medical students come from physician households. And that's only parents, right? Not even taking into consideration who their grandparents are, their uncles, their aunties. And human capital is it's the money, right? Ultimately, like income, those kinds of things. And these things interact with each other. The more social capital you have, the more likely you are to perhaps have some cultural capital. I'd never gone camping before I came to Yale, but the next place I'm heading to, I can say, oh yeah, I went camping in the Adirondacks with my classmates at Yale. And that is a way that I can create ties with people in ways that I would have probably not been able to, if I had, for instance, gone to Howard for med school, which was my alternative. So these different forms of capital really inform how we interact with others, how people perceive us, how people judge us. And in addition to the capitals that you have, or how people perceive how much capital you have, there's something called race status associations that also shape interactions. These folks are also social psychologists at Yale who do this work. So for instance, if a Black woman tells you that, or even a Black man in a hospital who gets IU patient transport, that is about race status association, where a lot of times people, assume that if you're Black, you belong at the bottom of the strata based on, whatever imagery they've been taught when it comes to race. Like, this happens to me pretty often. Are you transport? Are you here to take the trash out? Like, these things shape how people perceive us and ultimately judge us and interact with us, even whether they decide to have a conversation with us. And that has a huge influence on how your team will talk to you when you show up on the wards. So to that effect, a lot of minority students report feeling out of place, right, compared to a lot of their colleagues. So Sandra Peel's dissertation was on this matter. She calls this brand of students who are in the doctor dynasty compared to minority and or first generation students who really are not part of this like insider crew, right, of people who know exactly how to navigate the space. And then lastly, want to talk about stereotype threat. We already mentioned it earlier, but because of stereotype threat, the environment that we're in, as it turns out, so, standardized tests are supposed to kind of predict your performance at the next stage. And studies have actually shown that MCAT scores over-predict how URM trainees are going to perform in medical school, and if not most of it, is attributable to the nature of the training environment, right? Toxic environment, activating stereotype threat, and ultimately having a huge influence on how you're going to perform. Now, this is just standardized tests. Now, in person, like I said earlier, it can really impair like your performance when like on the words, right? Discussing when you get asked a question and you're feeling out of place, like has a huge impact on that. And quickly, I'm going to talk about like long-term implications. So if you think about specialty of interest, Black and Native students express the highest interest in non-primary care specialties. But interestingly, by the time we graduate medical school, we're most likely to go into primary care. And in spite of the amount of depth, right? Whereas like people going into ophthalmology have the least amount of depth, right? And think back to this hygiene, sanitation rather than surgery thing from 1910. So I think it begs the question, are we sorting marginalized students into undervalued specialties? Not that there's anything wrong with primary care, but the RVU system that we're working with does ultimately devalue primary care. I'm gonna run through these really quickly. If you look at like step one scores and like earning potential, it tracks pretty tightly there. And so as much as, because we value step one score, I think it has a huge impact on ultimate earning potential. And I talked about exposure to mentors. And this continues to, as we move along to residency. So, and then also when people move on to become faculty. So, there are disparities in NIH award. Black faculty are half as likely to be promoted, more likely to want to leave academia, and they're also within specialty income disparities. And our social networks yield fewer career opportunities in general. And so I want everyone to think about, how many Black friends do you have left from medical school? I think it's worth, asking each oneself that question. So there are impacts on individual mental and physical health. So Black students are more likely to experience depression, especially if they have a higher self-concept related to racial identity. So the more aware they are of their race. Surgery residents who experience racial discriminations are twice as likely to report suicidal ideation. And society level, Black people receive in general shallower health returns from their education compared to white people. And that probably has a lot to do with, one, discrimination in the workplace when you have an advanced degree, but also income disparities. Income is a huge mediator here. I'm gonna skip through some of these. I've already said it, there's been very little progress, and it really very much feels like it's a well-oiled machine that would take a lot of work to address. But something I don't want to lose sight of is that this has an impact on also non-Black people in medical school. The climate affects non-Black graduates' racial attitudes. It changes whether people are interested in serving underserved populations, and it has consequences for patient-centered care. I'll skip through the potential sources of a change. I think plenty of suggestions have been made, but I do want to show, though, that when external pressure is applied, there is change. The LCME applied new diversity standards, and there was a near immediate change in the number of Black women in matriculants, same with the number of Black students. So it's worth thinking about external pressure, but it needs to be specific. And then internal sources of pressure, right? The current intern class here in emergency medicine, significantly more diverse than before because of the efforts from the departments that led to what this class currently looks like. But there is backlash to be expected. So just think that this is not necessarily sustainable, or it may be sustainable, but it would require a lot of effort. So just want us to take that into consideration. And I've run out of time, so I'm gonna skip through what I think would be other suggestions. But thank you so much. I do want to thank Gina and Zach for having been my mentors this past year. Darwin and Marcella here at Yale, who have been doing this work, and other scholars, friends, family. And yeah, thank you.
Thank you so much. That was a fantastic round, eye-opening and so important. I think we can keep a few minutes for questions if anybody has any.
Hey, Max, this is Amaka Unanian, nephrologist at Penn. Thank you so much for the fantastic talk. And I know you had to kind of skip over some of your solutions, but I'm curious to hear your thoughts, you know, being an HBCU grad myself and you coming from an HBCU, how you feel the role of historically Black medical students can help with what, some of the things that you're discussing, being that they still largely produce the majority of Black physicians in this country.
Yeah, I think, having gone to an HBCU, there's an insight that we have that sometimes our Black peers who didn't go to HBCUs don't have. And I think, for instance, when you think about racial concordance is a good example. Like Black people who went to HBCUs experience less of the pressures that shape your ultimate outlook on medicine. And I think you and I have discussed some of this before, but I think going to med school in a space that can be a toxic environment probably ultimately has an influence on even how people respond, both to minority patients, trainees, whatnot. For instance, the experience of not being called doctor when you're the doctor, right, is something that's really especially common when you're in a PWI type setting, and that's not something that the medical students or the physicians that are in mostly Black settings experience. And so I think the distance, there's sort of like the social distance, not the COVID social distance, but the actual social distance between patients and provider may be different in part and shaped by the experiences of what it was like in medical school, right? If you're used to being stereotyped, to being used to facing microaggressions, you probably already sort of like put up a wall or a defense to assert your authority as the physician. So I think that probably is one way in which going to an HBCU is sort of like protective, I guess, against some of that. I don't know if I'm answering your questions.
Well, just to follow up on that, I'm just wondering how non-HBCU institutions can partner with HBCU institutions to work with some of the things that you noted in terms of the differences in grading and maybe different.
Oh, got it. Yeah, so I actually was going to talk about some of this. I think one, recruitment, right? Howard and Xavier send the most Black people to medical school, and most of them end up going to HBCUs. But I think non-HBCU, so the PWIs could be more earnest and intentional about broadening what they define as what would be a good candidate for their institutions, and really creating collaborations and pipeline programs between these institutions and HBCUs, right, to sort of like broaden opportunity. Because ultimately, at least to me, it feels like like the Penns and Harvard and Dartmouth and NYU kind of shuffle the same students around, right? Like they're not really expanding their pool of eligible students, and that's where a lot of change needs to happen, if you ask me. Is that useful?
Yes, that's exactly what I was asking you. Thank you.
Thank you.
Thanks, Max. I don't know if you can see the chat box, but there is a string of comments saying that it was a fantastic talk and that it was vital. Congrats on the job well done.
Thank you so much. Thanks for this opportunity.
Thank you for your expertise and time today. And for everyone else, please enjoy the rest of your morning.
All right, thank you.